conversation. So welcome to our bi-weekly RISE webinar series. This is session number 7 of 9 planned. And today we're going to talk about the rational use of oxygen. We have a wonderful lineup for you from Johns Hopkins University. We have Dr. Chad Hochberg and Dr. Souvik Chatterjee. Both have been instrumental here at our institution on implementing evidence around oxygen conservation. And then from CMC Vellore, I have Dr. Richa Gupta and Dr. Vanilla Chako, both of whom are professors in pulmonary medicine. As always, we have a really busy agenda. So we're going to start up with some welcome introductions. We're going to do a keynote address. And then we're going to jump into a case presentation. So Dr. Gupta and Chako are going to tell us really what are some of the challenges that they saw from CMC Vellore during the oxygen surge. And one thing I want to point out is, whilst India is moving past the surge at this time, we are about to enter viral influenza season, pneumonia season, and all of these other devices still require the use of oxygen. And so this conversation is still timely and there is opportunities for optimization. We'll move to a panel discussion. I have some great questions for the audience, for the panelists, but I would like the audience to put questions in the chat. And then we'll finish with an evidence-based review from Drs. Chatterjee and Drs. Chatterjee and Dr. Hochberg. So who is here today? Well, there's 407 participants who registered. Many of you are doctors, many of you are nurses. Again, we, like always at RISE, have a predominance of female participants. So 279 individuals are female. And we have representation from 24 states in India and 2 counties, with some of the highest registrations from Nagaland and Maharashtra. So very excited to see these states really coming to this conversation. Again, this is a conversation not for one individual, one cadre. This is a conversation for all, because all of us face an oxygen crisis and all of us need to think about how to manage these strategies. So what are we going to do today? We are going to discuss the need for the rational use of oxygen. We're going to identify evidence-based oxygen targets. And our GHU expert, Dr. Hochberg, has recently written a published article on this, and so has some great data to share with you. And then we're going to review some of the evidence-based strategies for oxygen conservation that have been adopted by CMC Vellore and by Johns Hopkins University. But before we get on to business, I want to take a moment to thank our hosts. So as many of you who have been regular participants know, that every session is sponsored by a host institution. In RISE, we name these facilities our hubs. These are our centers of excellence who have been supporting many of the trainings that have been happening regionally and nationally. They also incorporate some of the evidence-based experts that are making some of the national policies. Obviously, CMC Vellore is no stranger to anybody on this call, and I would like to invite Dr. Thomas Ram to please come and say a few words of introduction to get this session started. Dr. Ram, can I ask you to unmute and join the call?
Yes. Audible?
Yes, you're audible, sir.
Thank you, and a very good evening to all of you. I bring greetings from Christian Medical College, Vellore, and some of you would be following our lectures we're doing during the COVID pandemic, and we are very happy to get ourselves associated with Japan John Hopkins, and all of you are in the audience. I'm Thomas Ram. Actually, I'm a radiation oncologist by profession, and I also serve as an associate director for a mission network. And mission network is, CMC has a network of about 185 hospitals all around the country. And I'm happy to see many people in the Northeast who have joined. And we have quite a few hospitals in the Northeast and also in the remote places in Orissa, Bihar, Madhya Pradesh, and Maharashtra. So it's glad to see you all in the audience. And as we faced this pandemic last year, the first thing which we did was we set up what we call the COVID Command Center. And that's how I got involved, where I was looking after the training within the institution and also in our mission network. So on behalf of CMC and our COVID Command Center training desk, I'd like to especially express gratitude and appreciate. Most of you have gone beyond your commitments, beyond your call of duty to provide care to people with COVID, and also join this session this evening. And I'd like to also thank our resource faculty, especially from CMC, who have joined this evening to take out the time and share their experience, especially on rational oxygen use. So it's going to be very interesting. It's a little bit of a history where, our founder was Dr. Ida Scudder. It was in a speech during her first graduation in 1922. She made an interesting statement. You will not only be curing diseases, but also be battling with epidemics, plagues, and pestilences and preventing them. It was the same situation in 1918. And it is so coincidental that 100 years later, in fact, we celebrated the 150th birth anniversary recently, and the same words are getting echoed to the young people in our institution. And she gained strength not because she was good in her medicine skills or clinical skills, but she relied always on the presence of God to gain that strength. And her favorite prayer, I like to conclude with all of you. All of you are going through various challenges. I know that psychologically, a lot of people are affected at workplace. So this prayer was what gave us strength. Father, whose life is within me and whose love is ever about me, grant that the life may be maintained in my life today and every day, that with gladness of heart, without haste or confusion of thought, I may go about my daily tasks, conscious of ability to meet every rightful demand, seeing the larger meaning of little things and finding beauty and love everywhere, and in the sense of thy presence, may I walk through the hours, breathing the atmosphere of love rather than anxious striving. Dear friends, what you see on my screen is a QR code on the corner. And if you scan that QR code, you will find the entire series of 33 lectures so far, which we have done during the COVID pandemic. So you're welcome to scan the QR code or take a snapshot and keep and visit. It's on the YouTube channel for your information. So I'd like to extend my best wishes to this event. God bless all of you. Continue to stay safe. Thank you very much.
Thank you, Dr. Ram. Sobering words to start our session today. And our next session is actually on resilience. And I think prayer and is a big part of building resilience. So I very much appreciate those words. We do not see your QR code because I don't have it in my slide deck. If you do not mind, if you could email me or one of the RISE team email me, I will add it to the slides at the end and make sure it is kept at the end for all of you to be able to scan and really view your resources. And thank you so much for sharing. So on the backbone of this activity, I do want to mention quickly our RISE team. So for those of you who are new to us, RISE is a project funded by USAID, which is a part of a bigger entity, JPIGO. And this is the team that has been in the back, trying to build the relationships, move the work plans forward, come up with a strategy for how RISE can really support India as a whole during the COVID pandemic. And our team is led by Dr. Bulbul Sood, who's a strategic senior advisor, Dr. Sumesh Kumar, who is our country director and now currently in Delhi, and Dr. Vineet Srivastava, who is our fearless, non-tiring leader and program director for the JPIGO RISE Project Chief of Party. As I mentioned, these activities that we are currently championing are being funded by USAID. And so the webinar is like this very, very tiny tip of the iceberg, right? What's happening across up to 24 states is trainings within these hub facilities, engagement in activities to build ICU capacity, oxygen dashboard, oxygen ecosystem strengthening, identifying strategies to do health system strengthening, right? Not just focusing on COVID, but getting really ready, as Dr. Rama said, for the next pandemic. And Sangeeta Patel, Dr. Amit Shah, Cynthia Gear, and Vijay Paul have been instrumental in advocating both for the RISE project and other projects that are supporting India through this pandemic. So Cynthia, I would like to just invite you to say a few quick words to get us started.
Thank you, Dr. Bhakti, and good evening, everyone. On behalf of the United States Agency for International Development, USAID, I would like to congratulate Christian Medical College, Vellore, on your efforts to mitigate COVID-19. At the outset, we would like at USAID to share our gratitude to Dr. Ram and his faculty members at CMC Vellore for collaborating with us on this capacity building intervention for healthcare providers. And we'd also like to thank Johns Hopkins University, Johns Hopkins India Institute, and CMC College for collaborating with the USAID supported RISE team, like Dr. Bhakti just mentioned, implemented by JPIGO, to initiate this clinical case series that brings together clinical experts from the US and India to share their knowledge and experience on relevant topics of COVID-19 to COVID critical care providers from across the country. So USAID is very proud to be supporting this initiative, and I'm really honored to be with all of you this evening. These are very challenging times, and they continue to be, and USAID and India continue to stand together to address COVID-19. And as Dr. Bhakti mentioned, our COVID-19 collaboration builds on over 70 years of partnership and cooperation in health. And to mitigate these challenges posed by COVID-19, USAID is working closely with the government of India, state governments, and our partners to provide life-saving care and treatment, deliver public health messages and safety precautions to local communities, strengthen case finding and surveillance, build the capacity of critical healthcare workers, and mobilize innovative financing solutions to bolster emergency preparedness and recovery. So through this RISE project, USAID has been working really closely with various institutions that are the centers of excellences, or these hubs that were mentioned, that can build the critical care management capacity of several COVID-19 care facilities, bespoke facilities, so that healthcare providers across these RISE intervention states have the skills and information needed to treat the most critically ill COVID-19 patients. We really enjoy this fortnightly JHU RISE case discussion series that is part of our continuing capacity building efforts on critical care and COVID-19 management. So I look forward to today's session, which is focused on the very important topic of the rational use of oxygen during COVID-19 management. And we really believe that these events help address the capacity building needs of the providers and also promotes knowledge sharing as the pandemic further evolves. So I'd like to welcome all the participants who are attending today's session and really share our appreciation to the expert facilitators today. Thank you, and over to you, Dr. Bhakti.
Thank you so much, Cynthia. And I just want to make a shout out to our USAID Washington colleagues. Dr. Jackie Firth has joined. She's been very instrumental with her attention to detail to ensure that we can get this work done in a thorough and rigorous manner. So Jackie, thank you so much for joining us today, and feel free to come on camera as I continue with introductions. And last but not least, there is a team in the background that has been working tirelessly to put this case series together. And Drs. Valerie Osula and Dr. Pavna Seth have been working to put together a comprehensive resource sheet, which summarizes the evidence, which is distributed to all of the participants who join these bi-weekly calls. So thank you so much for putting that together. So it's time for work. I'm going to hand over to our colleagues at CMC Vellore, Dr. Richa Gupta and Vanilla Chaco to present, to take us back to like their playground, their workspace. What have they been seeing in the ICU? What are the oxygen challenges that they have faced? And what are some of the management approaches that have been adopted locally before we move to our panel discussion?
Hi, good evening, Bhakti, and everyone out there. So in next 15 minutes, me and my colleague, Dr. Vanilla Chaco, who is an intensivist, a very dynamic person, we are going to take you through a case scenario, a patient with COVID-19 in COVID times. So we have this Mr. X, a 62-year-old male and ex-smoker who presented to emergency department with complaints of cough with myalgia for 4 days, has fever for 1 day, which was 4 days back, and he has worsening breathing difficulty for 2 days. Examination, a quick examination in ED showed an SpO2 of 80% on room air. His BP was 140/86, respirate was 34 per minute, and he was losing all his accessories muscle. Chest examination revealed bilateral decreased air entry with the scattered B's. So as the patient comes in who is hypoxic, the first thing which you will do is you will put the patient on oxygen. So the staff there put the patient on oxygen with nasal cannula at 4 liters per minute. Saturation improved from 82 to 85%, but it was still low. So then she increased oxygen to 8 liters per minute via the same nasal cannula. So was this, do we agree on this? I won't. Now, if we don't agree on this, then why? So nasal cannula is a low flow device and it should be used to deliver oxygen between 1 to 4 liters or maximum up to 6 liters per minute. So this will provide approximately, 24% to 44% of FiO2. This, provided the patient's inspiratory flow demand and minute ventilation is reasonably at comfortable rate. Now, if the patient has high ventilatory requirements or high minute ventilatory rate, then he tend to take more of the atmospheric oxygen rather than the flow of oxygen which we are delivering by the nasal cannula. So the amount of the fraction of the oxygen which is supposed to be delivered by nasal cannula gets diluted with the ambient atmospheric concentration of 21%. And so patient will continue to have air hunger and will not improve in oxygenation. So in other words, we are wasting the oxygenation. We are not doing any, we are actually not providing any help to the patient. If simple words, if I have to put, if patient requirement is more than 6 liters per minute, then we should change the oxygen delivery device to face mask, which is ideal for delivering oxygen between 5 to 8 liters per minute. Or if the need is more, then we should change it to other appropriate delivery device, right? Now, further history from bystander revealed that patient has been having these symptoms of exertional dyspnea and cough for last 2 years, and he's been having winter exacerbation. He was not on regular medication, and he's an ex-smoker of 30 pack years. So after having this history, patient was initiated on treatment for exacerbation of underlying probable COPD. After 30 minutes of this, respirate improved a little bit. It became 30 per minute. Saturation improved a bit, 88%. Now the doctor comes in, asked to increase the oxygen, and ED nurse changed the nasal cannula to non-rebreather mask and increased the oxygen to 15 liters per minute from 8 liters, what she has initially given. Now the saturation improved to 96%, and with this, patient was transferred to respiratory isolation ward after doing the nasopharyngeal swab. Now in the ward, when the sister took over, the respirate was little better. It was 28 per minute, but he was continuing to use his accessory muscles. There was increased work of breathing. Saturation was good, 97%, but in another few minutes, or say 30 minutes time, sister noticed that the patient appeared drowsy, right? So now what is the most likely cause for this patient? We are suspect, is it something like sepsis which is setting in, or it is something like electrolyte imbalance, or it is carbon dioxide retention. So in this scenario, where we know the patient may have, gives history suggestive of COPD, probably has a viral infection which has exacerbated his underlying COPD. He's been administered very high flow rate of oxygen. Most likely this patient is having carbon dioxide reduction. So most likely cause in this scenario would be CO2 retention. So what should we do next? What we should do next is a previous slide. What we should do next is we should reduce the oxygen to maintain the saturation between 88 to 92% in patients who have high likelihood of retaining carbon dioxide. We should have a clinical assessment for signs of hypercapnia, and of course, facility exists, we should look for the arterial blood gas analysis. Next slide. So again, this nasopharyngeal swab came positive for COVID. Chest X-ray showed bilateral shadows, and ABG was done, which shows respiratory acidosis with hypercarbia. The patient was initiated on NIV with BiPAP at following settings with 4 liters of oxygen. Repeat ABG after 1 hour showed some improvement with decrease in work of breathing. So overnight, patient was continued on the same management. But next day, on rounds, it was found that patient has increased work of breathing. He's again requiring increased oxygen, and chest X-ray has worsening shadows. So these were the chest X-rays, which clearly showed that within 24 hours, the X-ray has become really bad with bilateral worsening shadows. Next, please. So at this point of time, we had a call with our ICU consultant regarding shifting out of the patient to ICU, but she said that there was only 1 bed available in COVID ICU. So from here, I hand over to Dr. Vanilla, who will take through the this case further.
Good evening, everybody. I'm Vanilla. I work in the ICU, and the situation which Richa took you through is a common situation which I'm sure many of you would have gone through. We all know this, this problem of beds and bed crunch. And you must be wondering why I'm talking about triaging of patients in a session on oxygen conservation. But it's extremely important, because if you get, a patient who's unlikely to benefit from ICU care, you're not doing justice to the system at a time when oxygen, conservation is our prime focus. So in CMC as well, before the first wave, we did go around, I think every institution should do this little exercise of setting out triaging criteria. So we did use a little bit of background triaging criteria which were available from international guidelines. And the key is to make it as objective as possible. I think the first step is to decide whether the patient actually needs ICU. How do you decide that? That depends on whether the patient has either respiratory failure, which requires some kind of ventilatory assistance, or if the patient has 1 or more organ failure. So then those are the criteria which is, okay, fine, this is the patient who may benefit from ICU. So that is step 1. The second step is to say, are there any potentially unsalvageable factors? So in a time when the beds are a prime commodity, it is very important that as physicians, and hospital healthcare workers, it's important that we try and identify, do the patients have any potentially unsalvageable factors which would preclude the patient from getting an ICU admission. And we had identified a set of factors for our institution, which included, you can see almost like end stage organ dysfunction, either related to the heart or the lungs, or neurological disease, severe neurological disease with patients who was dependent for all activities of daily living, or advanced chronic liver disease, or an active malignancy or end stage malignancy. Those were criteria which we put down as potentially unsalvageable factors. And then we set out, we set out to put a priority list based on salvageability. This is what we used in the first wave. And you can see that it's a fairly simple set of criteria that we had put in criteria as high, moderate, or low. And what we put was an age-based criteria and a person who was physically active versus someone who was, as the dependence increased, the priority for ICU admission went lower down. Now, this worked reasonably okay for the first wave because we didn't have that higher burden of cases. But as the second wave came in, there was the faculty who were involved with triaging actually went through this struggle. There was like a moral distress. People were actually struggling to actually make the decision, should this 40-year-old get in, should the 50-year-old get in, should the 30-year-old get in, who gets in, because there was a big group of patients. And that's when we tried to make the criteria a little more subjective, objective, based on hard criteria, PF ratios, which is actually it's from an arterial blood gas, where we measure the ratio of the partial pressure of oxygen in the arterial blood to the fraction of inspired oxygen, looking at the respiratory rate, work of breathing, and other organ dysfunction and comorbidities, and set a score. Now, this did not, we have not actively studied the benefit of this, but putting these criteria into place for the second wave did help a little bit in at least the faculty who were involved with triaging to objectively decide, okay, fine, this person's going in and this one's not. Now, there are a lot of criteria which are available on the internet, which have been set out. There's a good article by Charles Sprung on triaging criteria for ICU. So this gentleman, Mr. X, has come into the ICU. He came in with worsening respiratory distress, as Richa said. And one thing we did notice in our first wave, as we started managing patients, we were learning on the job. We noticed that a lot of patients, even though the initial recommendations were to intubate patients for safety of healthcare workers, we actually found a lot of patients doing well on NIV, non-invasive ventilation. So in our ICUs, we have ventilators, but if you don't have ventilators, you could use a BiPAP machine. But what we found was actually most of the time, all patients need is the positive end expiratory pressure. That's what actually keeps your alveoli open at the end of expiration. And the extra pressure support, which is given to the patient during inspiration. So when they take a breath, the ventilator tries and assists you. So that extra support, which is given to the patient in inspiration, was actually not needed. In fact, patients who were given that extra pressure support during inspiration, they actually didn't tolerate non-invasive ventilation very well. And so we used to just keep them on titrated oxygen and positive end expiratory pressure of 8 to 10 centimeters of water. And the most important thing is to make sure that your patients have minimum a leak around the mask, because that can increase your oxygen consumption. And it's very important that we set out, as a blanket rule, not just for COVID, but even non-COVID situations in ARDS, our standard recommendations is to titrate a saturation of 90 to 92. Now, this gentleman had COPD. Our saturation target was lower. It was 88%. In addition, we were actively proning patients. This is how we prone our patients on NIV, and additional medical management, which I'm sure all of you are familiar with. Antivirals, there's not much of a role, but role of dexamethasone, and all our patients were on intermediate dose anticoagulation. There's just a little bit of a background to show you that in our setup, we've actually managed a lot of patients on NIV, and out of which 2/3 of the patients were successfully managed on NIV alone without requiring intubation. And it was not just mild ARDS, but even patients with severe ARDS actually had success with NIV alone. They were managed with NIV alone. And so now this gentleman was put on NIV. Most of the time we see them improving, but this gentleman remains tachypnic. So his work of breathing goes up and the oxygen requirement goes on rising over the next 48 hours. What do we do at this stage? Okay, you can see here, now this is just a set of blood gases which I've put here. What I talked about earlier, that is the ratio of the partial pressure of oxygen to the fraction of inspired oxygen. For all of us, normally it should be around 300 to 500 because we have a partial pressure about 60. FiO2 of room air is 21, 60 to 100. And you can see here that he's what we would say a moderate ARDS, acute respiratory distress syndrome. And you can see that his oxygen requirement also is steadily going up. And along with the drop in the PF ratio. So as it's dropping, it indicates that his lung function is probably getting worse. And additionally, you can see that he's also developed a respiratory acidosis. His pH has dropped less than 7.35, and he's got a CO2 retention as well. So this gentleman definitely needed intubation, but sometimes it is not as clear as this. And it's very important. an additional measure to conserve oxygen is to time your intervention appropriately. There's no point in keeping them endlessly on NIV or endlessly on the Venturi mask. It's important to time your intervention. If you time it appropriately, patients actually do well. And this is again evidence from our center, where we found that patients who were intubated early, after if they didn't respond to NIV, intubating them within 3 days, the patients fared much better than intubating them at 5 days. So this patient, again, as I said, so timing of intubation is important. It is also important that you appropriately set your ventilator, because if you don't set it the right way, that can also cause worsening lung injury. So ventilation is to assist the patient, but if you put the wrong settings, you can actually worsen the patient's condition. Now, if you see here, when a patient has got very stiff lungs like COVID or any other ARDS, this pressure here, I can't tell you too much about it, but can give you an idea as to how the lungs are. So here the pressures, ideally what we're talking about is something which is known as plateau pressures, which are the pressures in the lung, okay, that should be less than 30 centimeters of water. You can see here that this peak pressure is usually higher than the plateau pressure. That itself is 19. So this indicates that the lungs are fairly compliant. And so it's important that you ensure that the patient has safe volumes. Now this patient's volumes are too high, obviously. Low tidal volumes of 4 to 6 ml per kilogram of the predicted body weight. Your PEEP setting should not be too high. So for very bad ARDS, sometimes you set PEEPs of 12 to 15 centimeters of water, but in ARDS, COVID ARDS, what we found is setting the PEEP of 8 to 10 centimeters of water helps in, is much better preferred. And all along, making sure that your lungs are safe. Again, I'm stressing on this in this session because all this helps in conserving oxygen. If you set wrong settings, if you set too higher settings, that can cause worsening lung injury and increasing oxygen requirement. This is another situation which we see very commonly. So this gentleman, if he develops subcutaneous emphysema, generally we would try and put them on 100% oxygen. Now this patient has got a clear-cut pneumothorax. Important to put the chest tube early. No point putting them on 100% oxygen. This pneumothorax is fairly big, but even if it's a small one, probably better to put in chest tube early. So he was continued on lung protective ventilation. In addition to ventilatory strategies and timing of intervention, it's very important that patients with COVID ARDS, in order to optimize your oxygen usage, you must make sure that they are as dry as a bone. So we aggressively diurese our patients and treat infections whenever it happens. And our targets all along is to ensure that the saturation is 88 to 92%. If you've got an ABG, make sure that your partial pressure of oxygen is 55 to 70 millimeters of mercury. And additionally, remember, it's not just that target, but to make sure that your oxygen is actually reaching the tissues and the organs, because if you don't have a good blood pressure, your oxygen which your lungs are getting is not going to reach your organs. And it's important to have a good hemoglobin, at least more than 7 grams per deciliter in patients without heart disease. Now, this gentleman actually went home. He had a tracheostomy, he got decannulated, he went back home, and this is his follow-up X-ray when he came back. So I think I'll stop here because Richa will probably be covering some of this in the questions, Bhakti, and we can discuss this along.
Yeah, I think because we are running with 15 minutes, so we can discuss this later during the panel discussion.